Hello, hello. Happy Thursday. It's me, Dr. Cindy Duke, Medical Director and Physician and Lab Director at the Nevada Fertility Institute in sunny Las Vegas, Nevada. Check it out, guys. I've got a background and it's blue, which is, as you've probably already figured out, one, if not my favorite color. I'm also a PhD trained virologist. And so I have been using some of my extensive knowledge of the field to help inform our conversation. I have maybe 15 to 20 minutes here, and then I'm off to work. Yes, I'm still working. I'm primarily doing telemedicine. And so what that means is I'm seeing patients via video consultation virtually. Telemedicine is a great way, guys, to see your doctor if you don't have an acute situation that needs to be seen in the office. Telemedicine is awesome. You can see your doctor face to face. You can go over your symptoms. For many patients, they actually have ways of tracking your vital signs remotely. And certainly, if you're someone with, say, history of diabetes, high blood pressure, issues like that, it's really, really a wise idea to keep a thermometer in your house, a blood pressure cuff in your house, and of course for diabetics, your glucometer, a way to test your sugar. And of course, you should be testing your sugar even when you are not having acute issues with your diabetes. That should be part of your regular maintenance for your health and your diabetes. One of the really neat things about telemedicine is you can see your doctor from your house, from the comfort of your own home, but you can also see your doctor from work. You can see them in the car. I've been having so much fun with my telemedicine visits, in part because I get to see a lot of my patients in their own element. With the shutdown, it also means I'm getting to see my patients while they're at home with, say, their dogs. So I've had at least 4 appointments in the past week where my patient's there and so is the dog. And it's fun. It's fun. It's absolutely fun. And so I'm here to encourage people to do just that, see your doctor via telemedicine. If you're not sure whether your doctor offers telemedicine, call them up. And if they're not, you asking about it will encourage them to look into it. As someone who's actively done video medicine consultations since 2016, it's doable. The learning curve isn't very steep if you are a doctor or a healthcare provider watching me right now. And I'm also happy to help guide people into doing telemedicine if that's something that you were interested in learning about. Absolutely. I'm here, available, and ready to teach. For those who are based in Trinidad and Tobago and viewing today, or who follow the news in Trinidad and Tobago, I did appear on TV6 this morning. I was on the morning program with Mr. Fazir Muhammad, and we talked a little bit about coronavirus. We talked about COVID-19 and really the long-term outlook. And so I wanted to do this live in part to follow up on that conversation. I worry that maybe some people would think I was talking more doom and gloom, but I was not. He asked me simply a question of what do I see happening in the long term? Are viruses and pandemics here to stay? And I explained that we will have other pandemics to come, but in the immediate conversation as it relates to coronavirus and COVID-19, we will have more outbreaks even after we get containment. And certainly I am here to remind everyone that containment is coming if we all take personal responsibility and follow the recommendations, which are, good hygiene practices, washing your hands with soap and water or an alcohol-based sanitizer, 60% alcohol minimum, wearing a mask if you must go outdoors, maintaining distances of at least 6 feet or 2 meters from other people when you're out and about, not congregating. And honestly, that was one of the conversations that I had with him, was that the not congregating recommendations are going to be around for the foreseeable future. The truth is, we need to be able to have an effective vaccine before we can truly start telling people to go out there and congregate and just be laissez-faire about things the way we were before COVID-19. And that's because this is a very highly contagious virus. Underlying health issues are not going to change. And of course, as we all know by this point, I hope, it's not just people with underlying disease who are being affected with the infection and then COVID-19 disease. And that's because the impact that this virus has on your body is based on not just whether or not you've been exposed, but also on how exposed have you been? How many times have you been exposed to the virus? What was your inoculum, or how much dose of the virus did you essentially get? You know, that sounds probably a little bit weird, but it is proven. And as a virologist, as someone who deliberately infected cells and organisms with viruses, the amount of virus you infect with did make a difference and determined the extent of the disease that the virus would cause in many times in these different models, as well as the immune response. It will change it. The premise is also how we do most viral vaccines, which is we cause mild infections so that your body can then learn to recognize what an infection looks like and what an appropriate response to the infection is. And so I just want everyone to know that. And that's something I really tried to emphasize today, which is takeaway points, right? Coronavirus is here. It is infecting a lot of people. At least 80% of us will be infected. Most of us will be asymptomatic, so we will not know that we were infected, which is part of what makes this a crisis, is the asymptomatic folks are the ones who are more likely to spread it because they don't know that they're infected, and therefore they're probably not going to take the same quarantine and isolation precautions as someone who's known to be infected. And it will be here until we at least have more effective treatment for it, and definitely until we get a vaccine. Now, in the meantime, what can we do to protect ourselves, protect our communities, and try to at least get back to some form of regular life while we wait? Because I think that's what everybody's asking now, right? Is, are we just going to lock everybody in their houses forever? And obviously that won't do. It will not do. But at the same time, we do have to still keep some of these practices going. So we need to continue with our hygiene. We need to continue wearing masks when we go outdoors. But we also need our regulatory agencies and our health agencies to start coming up with ways to more readily screen, meaning test us, to know who's asymptomatic so that everybody can know their status, right? We've done this with HIV. We've done it with other highly communicable and worrisome viral infections, is know your status. And I think we need to start campaigning for that as humans, as individuals, to those who have the power, those who have the decision-making power. We need to ask them, as things start getting more under control, because obviously many of them are currently embroiled in containing this pandemic, but we need to also start looking ahead. If we are to get our economies going again, if we're to be able to get people back to work, if we're to be able to get people traveling again, we need to have more readily available testing and quick testing that's reliable. And you know, those three things are really important: readily available, rapid or quick, and reliable. And you know, at the moment we're struggling with all three. We don't have readily available testing in most places. We don't have rapid testing if it's available, meaning currently it's still taking for most places somewhere between 4 and 7 days, maybe just 2 days in a few places to get the results back. And then reliable. So we know that current testing modalities still have a fairly high what we call false negative rate, meaning we can't just rely on a negative test if someone has symptoms, especially. And so if you were told you're negative, you still have to practice a lot of the safety precautions, because it may well be that you're positive, but the test didn't detect it or didn't detect it yet. But at least we can find the majority of people. Even if it's going to miss some of them, we'll find the majority of who's positive, because that's part of it. Is even though we don't have treatment, we need to be able to identify those who are positive so they can clear their infection, be in isolation and clear their infection before they start reintegrating into the general public. And then that is especially so for our healthcare facilities, because what we know from seeing what they've been doing in Wuhan, what they're now doing in Italy, what they're starting to do in New York City, is you do have to separate the positive patients from those who are not positive, in terms of testing at least, to help decrease spread and to really also protect your healthcare population. And so it's really important that we talk about these things and know how we start looking ahead, because it will take policy changes, and not just short-term policy changes. We're going to need health policy to change and protocols to be put in place everywhere. We need universal protocols. We can't just rely on the people at the airport asking someone if they've traveled recently to a hot zone. And the reason why we can't just rely on people at airports asking folks if they recently traveled to a hot zone is because now we know hot zone status really refers to symptomatic disease, right? Yet somewhere between 4 out of 10 to 8 out of 10 people who are actually positive for the infection don't have symptoms. So someone may well return from someplace that's not considered a hot zone because there aren't a lot of people dying from the infection, COVID-19 disease, but it may be a place a high infection prevalence. And so it's not enough to be asking people questions like that. You're going to need a lot more protocols in place and a lot more checks and balances, not just the airports, not just when people have symptoms. We need a little bit more objectivity in screening people once we get it. And so it's time for us as people, as we learn more about the virus, learn more about how it works, learn more about its characteristics, and learn more about the fact that it's in people who are asymptomatic. We need policy changes to emphasize testing, 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 testing. Know your status. We need to borrow that tagline and that logo from other campaigns. It's time to start thinking long term, because that's the only way we're going to help keep this from resurging once we get the first wave of containment. Because again, we're not going to be able to keep everyone in their house forever. It's just not practical. It's not realistic. And of course, for an economy in the long term, we need to get back out there eventually, but we need to do it safely. You know, I say that as a physician whose clinic is closed in terms of regular, usual activity. I'm actively looking at ways to reintegrate and reincorporate my clinical care while keeping all of that information in mind. How do I factor in the asymptomatic patient or employee? How do I keep the patient safe from the asymptomatic employee? And how do I keep my employees safe from the asymptomatic patient? And that is how we all have to start looking at things, whether you're a business person, whether you're a teacher, whether you're a government official, no matter what walk of life you're in, whether you're an entrepreneur with a restaurant, whether you're a theater owner, you have to start wondering about all this, because masks alone will not stop spread. Washing our hands alone will not stop spread. It's important, though. It helps to curb spread. And staying home, which is probably the most effective way of decreasing spread, it is, it really is, isn't enough in the long term. So we need more to be done. Let's see what some of the questions that we have so far. Because like I said, I won't stay forever, but I want to make sure we get to as many questions as possible. And it looks like the feed is frozen. Okay, what happened there? How long did that happen? Okay, so can you guys still see me? If you can, go ahead and give me a thumbs up and we'll keep going, but let me know if you can still see me or not. Okay, so yes, we can see. Hi, Dr. Stewart. Nice to see you. I'm glad. Thank you guys for that information. So let's see if we can get to some of your questions, because again, the goal today is to keep this at a reasonable time frame. So here we go. Here we go. So Avian says hi. Hello. Hello, Avian from Louise. Locked on, please stay safe. Doing my best to stay safe, Louise. I'm actually working from home, as you can see, and working with technology as well, which has its drawbacks. Looking for questions, looking for comments. Missed it. I'm working on getting a recording of this morning's appearance, and as soon as I have it, I will share it. I do have one shared on my personal page, but it's not the official recording from this morning. We have here from Ruth Prasad. So someone mildly infected may have a relapse since the load of infection may not have affected them in a way to build up full immunity. Well, Ruth, that is a very good question for two reasons. The first is, it is not yet clear if immunity is lasting. So, for example, as I've mentioned before, this coronavirus is part of a family of viruses that includes the common cold. And as I'm sure most of us can recall, we've had the cold and had it more than once. So, is it conferring lasting immunity is the first question. And the only way to answer the question of lasting immunity is time. It takes time. There's no way for a pandemic that's really been waging for the last 4 months to be able to tell people with any absolute confidence that they have lasting immunity if they were infected and developed an immune response. But the second is it an actually protective immune response that they developed? We don't know that either. So is it lasting? Is it effective? Those are still questions that will take time. So the short answer to your question would be you could be infected again because of those two reasons. But the second could be because there are multiple strains of the virus. And so you may be infected again, but the hope would be that even if you're infected again, if you have some immunity to the virus, if you did in fact develop immunity, it would be a weaker form of infection in terms of your body being stronger at fighting it off and keeping you from having a truly bad outcome. And so those are some of the things to keep in mind, questions to ask, questions to think about as we go through this, because there's still information being gained. Until then, we have a personal responsibility, and that's what I'm here to talk about. It's the personal responsibility. Our personal responsibility is to wash our hands, wear a mask when we go outdoors. Remember, if you're wearing a mask, you can't be touching the mask and then touching everything else, or else you're still spreading things. Using 60% alcohol-based sanitizers if you don't have access to soap and water. Staying home or maintaining distance of 6 feet or greater. And that's because of the fact that the virus can be aerosolized. And then the bigger issue is getting our stakeholders and our decision makers to understand that we need to start understanding how do we get to know our status. Because until we know that, we're sort of still blind in the dark here. We're taking personal stabs in the dark because we don't even know whether or not we're the ones endangering others, so to speak. I hate using the term endanger because it's not like it's deliberate in terms of most people. It's just that you don't know. So we need to know our status. Going down to our other questions. From Earl Henry here, he says, what therapies would you suggest that a person do if he or she is at home with COVID-19 symptoms or have been diagnosed but is at home waiting to be healed? So I would presume that what Earl is asking me about is the person who's at home with mild symptoms. So maybe they have a cough, they have some mild fever, but it's improved with Tylenol. They're at home with maybe the muscle aches, etc. So Earl, the key things are first and foremost, hydrate, hydrate, hydrate. Stay hydrated. If you're at all having difficulty breathing, however, this is not the time to stay at home. You need to call your doctor, explain what's happening, and have them instruct you on where's the next best place to go from your house. If you're having chest pain, tightness, you just don't feel yourself, you're unable to stand up. Maybe you're dizzy every time you try to stand up, or you're near faintish, or if you've actually fainted, you know you're at home with COVID-19, you were told it's mild, but now you're having symptoms. Don't stay at home and try to ride it out. Call your doctor, and then they will tell you where to go and where to go quickly, because this is a virus where the disease can progress slowly. But for some people, particularly young, healthy people who have what we call a lot of lung and cardiac reserve, you may not realize how sick you're getting until it's much later than we would like you to present to the hospital. So if you're starting to have symptoms, definitely call. But other things you can do, like I said, drinking water, trying to maintain a little bit of a routine, get up, brush your teeth, eat, right? Nutrition is important to help your body recover. Even if you don't feel hungry, you're going to need to eat a little something on a regular basis. So even if it's as simple as some oatmeal, soup, right? People talk about vitamin C and vitamin C's potential to help your immune system fight off an infection. A lot of that has to do with the before infection part. If you're someone who usually takes vitamin C, I'm someone who takes Emergency on a regular basis, then sure, you can still continue taking that, but the key is what we call supportive management at home. So treating your symptoms. If you have a fever, taking your acetaminophen according to what's written on your packaging or what your doctor specifically told you. If you're having a cough, if you prescribed a cough suppressant, sure. If you're having muscle aches, the Tylenol for your fever usually helps with that. If you have underlying issues like diabetes, making sure diabetes is well controlled. If you're at home feeling sick, that is not the time to stop taking your insulin. It's not the time to stop checking your blood sugars. That's the time to do it. Make sure you're also checking your blood pressure if you have blood pressure issues especially. And so those are some of the things that you can do. From Ruth, she says, thank you for your excellent response. Understood. My pleasure, Ruth. Cora Panton says, would you prescribe the medication that President Trump is promoting? I would not. That medication which she's asking about is called chloroquine or hydroxychloroquine. This is a medicine that needs to be prescribed by someone who has actively done it before, who has been trained in how to prescribe this medication, and who actually knows how to monitor a patient closely once they've been started on the medicine. Now, there are clinical trials currently ongoing to see, first of all, is that medication actually effective at treating COVID-19? Is it effective at treating all COVID-19 patients, or is it specific patients? Again, guys, remember that we're still characterizing the illness that is caused by this infection. We're still characterizing it. So it's premature to say this thing treats it or this thing doesn't treat it. People are investigating. Please allow them to investigate. And there are multiple candidates of medications being investigated. It's not just this one drug. There are interferons being looked at and a host of other medications. It's not just one. And it's important to know this because some of the messaging can come across as if there's a smoking gun or one for sure medication. There is not. And some of the trials actually looking at that particular drug that POTUS has talked about have also shown that one trial had to be stopped because of adverse events happening in the patients within the trial. So let's give it time. Medicine and science takes time. It's the reason why doctors and scientists spend time designing the studies, having to get them approved, having their peers review them before they're allowed to even start testing them out in other humans. It's important that we allow this process to still go through the checks and balances for safety, okay? The same goes for vaccines. As we know, there's a significant movement of people out there who don't even believe in vaccines. The last thing we want is to not do the vaccine preparation, design, studies, safety, and efficacy verification that would only in the end, if we didn't do it correctly, lead to furthering the cause of folks who are anti-vaccine when they're using misinformation. We need to be sure. Allow the science to do so. I know we're all tired of being at home, but science and accurate results takes time. Sharon says, folks are telling me that they have no appetite. They have a bitter taste in their mouth. Therefore, getting them to eat and get some nutrition in the body is a task. I agree, Sharon. And I happen to know that Sharon has been communicating with me privately. So I know she works in healthcare with older patients usually who are affected by this. And so many times, you know, some of these patients may need additional nutritional assistance. They may need a nutritional, what we call consultation, and their providers may have to even give them medicine through a special tube or intravenously. That is something that their doctors will determine based on their nutritional status. But we do need good nutrition, balanced nutrition, to help our immune system fight off infections. Like I said in an Instagram live yesterday, if you're someone who is seeking a healthy diet, because I've gotten a lot of questions about what's a healthy diet to fight off infection. It's a balanced diet. This is not the time to starve yourself. It's not the time to go on a complete fast when you're sick. You actually want to have enough balanced nutrition coming in to help your body, even though you don't have an appetite. I understand that. I understand you won't have one. We all feel that way when we're sick, but there's a rationale behind why we should eat. Hi, Dr. Kelly. Hi. Happy Thursday. I'm looking to see if we have any other questions. Jillian says, I live in New York. What is your take on New York being one of the hardest hit cities? My take is that it's not entirely unexpected given how close people live and work together in New York City. Of course, I try to keep my conversations apolitical, meaning no politics, but although the United States was one of the last countries to be hit hard, we didn't take as many preparatory steps at first as we probably could have if we had paid a little bit more attention to what was happening across the world. You know, we didn't have testing kits available that could give us rapid diagnostics. And so there are a host of things that did contribute to what we're seeing in New York. It's not that New Yorkers have weaker immune systems compared to the rest of the country. It's not that New York doesn't have the resources. It's that the virus really spread. And of course, in terms of social distancing, sorry, 1 second. A lot of people weren't practicing social distancing even when they were told to. A lot of us didn't believe. 1 second, there's a phone ringing here and I'm trying to locate it to stop it. And so, you know, having been in groups and on summit calls where doctors who are in New York City working, who are epidemiologists, intensive care unit, intensivist doctors in New York. And one thing is clear, they said that for a lot of the outbreaks, you could track it right back to a gathering of people. And so they were able to track a lot of the surges that they saw coming into the hospitals in New York City back to events, concerts, shows, gatherings, and we're seeing that even in Detroit. So in Detroit, they were able to track one of the big outbreaks that's currently happening in Detroit amongst people of color in Detroit to a pancake breakfast and also to a fundraiser for the local police department. And so it's very clear, and it's why I'm saying we need to think long term. The truth is outbreaks happen when people congregate because you'll have a combination of things going on in a congregation. You'll have people who are carriers don't have symptoms. You'd have people who have underlying disease who can get quite sick even from a fairly mild infection. But you also have a lot of people repeatedly interacting with each other, and so the inoculum dose is higher. And it's important to know that. From Sharon, she says, I'd love to hear your talk about the crisis standards of care. I sat in on a meeting with providers, and it's so tough to learn about the scoring tool being used to assess patients. Please share your views. There are protocols developed, I have to say, in many countries that have now gotten control of their coronavirus situation. They use protocols. Like I mentioned on a number of other programs, we've all looked in wonder, in awe at the rapid speed in which China built their coronavirus hospital in 10 days so that they could isolate. But it was important. It's actually part of what they noticed, which is that patients who were positive, whether or not they were symptomatic or not, needed to be removed from general patient population so that they could have a assigned group of healthcare workers taking care of them who were wearing the appropriate PPE, and also to really help them target the use of resources. And so we need to start moving toward that. I know I wrote about this 2 weeks ago at this point. Time, my goodness. And my recommendation was that even as states start using the monies allocated to them with the huge relief fund, they also need to start looking at how are we going to, in the long term, keep the coronavirus patients in a separate location when they're being assessed by hospitals, etc. And that's not new, guys. We did it for tuberculosis. It's what they started doing at the turn of the century to really start understanding and keeping TB patients away from general population and hospital population. It's what we've done when we designed hospitals. It was in thinking about things like TB, where you need special negative pressure rooms to prevent the aerosolization of fomites and spores of TB. The same plan is going to be needed long term for coronavirus and other viruses. This is not going to be the last pandemic, but hopefully we can really have a better control over that. From Erlene, she says, I'm diabetic and the disabled individuals I take care of have coronavirus. I'm at home for the past 3 weeks, but I don't have any symptoms. Should I return to work? I'm going back on Monday. Thank you. I think, at this point, Erlene, this is a question that you should ask your healthcare provider, as well as talk with your facility to find out if everyone where you work has been tested and what's their status. Some people may have been coronavirus positive in your facility, but if they didn't test everyone, again, you may not know what you're walking into. So it brings me back to what I was saying, which is we need to know status. And it's time that we have more testing made available, rapid testing, so that we can care for everyone. So your example is perfect, which is you're taking care of patients who are high risk. They need to be tested. But you are also technically high risk. You need to know the status of who you're taking care of so that you can take precautions. Also, for the long term, any healthcare facility, any healthcare provider taking care of a patient really should have the basic minimum. So you should be talking to your employer. If your doctor says you can go back to work, you still need PPE. You need a mask. You need gloves. You need the basic protections for your job. That's important. It's important. Let's work our way through to see what else we might be missing here in terms of comments. And I love it, guys. I love the interaction. And I'm seeing, comments here from folks in YouTube, folks on Periscope, and folks here on Facebook. So I'm really enjoying it. I'm looking here to see what are the comments we have and how we might be able to address everybody's questions and comments before I tune out today. I think it's important that we talk about it all, and I want to see that we're not missing anybody who has something that they'd like answered on air. In the meantime, what am I up to? Like I said, I have patients to see this today. I'm also working on other things for my clinic and my patients so I can get back to doing cycles. But in addition to that, I will be on Instagram Live at 4 p.m. Pacific today, 7 p.m. Eastern Time. I am doing an Instagram Live with two doctors who are at Johns Hopkins Hospital, and we're just talking about COVID-19, women's health, what is coronavirus, and also one of the doctors is a maternal fetal medicine, a high-risk obstetrician who's also an intensive care doctor. Yes, guys, they're such doctors who do both. And so we'll be talking about all of that today on Instagram Live, not Facebook. Victoria says, yes, because I'm so ready to continue my IVF treatment. Agreed. And it's time for us to really get a hold on this. It's not enough. It's needed. Don't get me wrong. We need to be at home. We need to practice physical distancing. We need to wear our masks. We need to wash our hands. We need to do all of that. But we also need those in charge to start thinking big picture. What are we putting in place? How are we going to get people back out there, but give them the confidence to get back out there, knowing that if an outbreak would have happened again, we'll be able to diagnose it quickly because we have testing. We'd be able to have protocols in place so if someone shows up to a hospital, the hospital and the hospital staff knows what to do right away. We need those things in place so that we can all feel assured that it's okay to get back to the living of life. And we're humans, we're resilient. We want to do this and we will do it and we'll do it well, but we need some safeguards in place. And that's all we're asking. Decha is saying also, what makes this strain not affect children in the same way? It might be a couple reasons, Decha, but I should also caveat this by saying some children are being affected pretty severely. But the truth is most children are very healthy. Like I mentioned in a prior live, most adults have some underlying heart things starting. We're starting to build plaque in our arteries. We're starting to build cholesterol plaques in our heart. You know, our function, our lung function may not be as perfect as we'd like to think it is. Children, they're not really building plaques yet, nor are they having our artery disease, coronary artery disease just yet. So they're healthier at baseline, most of them. And so that's part of it. And their immune system is also younger, probably more responsive. And so we'll get more information about why children seem to generally be doing better. I'm actually glad they're doing better because, gosh, guys, wouldn't it be even worse if kids were doing worse or worse than us? Oh my goodness. I'm at least happy that kids tend to be doing better, but it doesn't mean that if you're a parent, you should slack off on protecting your kiddos, right? And especially if you're a parent with a kid with asthma, lung disease, heart disease, type 1 diabetes, your kid is a high-risk kid. Don't take chances, okay? Working our way through. Who else do we have here? One question, Detra says, so how similar is this COVID-19 to other coronavirus strains that already exist? Can a vaccine be made from predicting? Well, they're still figuring out how similar. It definitely bears similarities to SARS, and that's why the name of this particular virus, the official name is SARS-CoV-2, because it does have quite a few components that are very similar to SARS. Will we have cross-reactivity, cross-protection from this coronavirus infection for other types? We don't know yet, and that's part of why it takes time to design a vaccine. I would say currently the primary focus of the vaccines being designed for this pandemic has to do specifically with this virus. Later versions, I'm sure they'll work on incorporating other what we call antigens and other proteins that are more common across all coronaviruses, but the first step is really just getting this one under control. People have tried in the past to create vaccines for other coronaviruses, including the common cold and SARS. One SARS vaccine candidate got pretty far. It was actually being worked on right here in the United States, and then funding was discontinued for that project. At this point, I think that project is back up and running, and so hopefully what we'll get out of this is not just funding for coronavirus, SARS-CoV-2 virus, but with other vaccine studies having been refinanced, perhaps we'll get others as well. Alicia says, hi, Doc. Saw you on our local TV this morning. Thanks for sharing the info with us, Trinidad and Tobago. Thank you, Adina. Actually, it was Adina, not Alicia. Thank you so much. I enjoyed being on that program this morning, and I wanted to come to just let people know, although I was there talking about the long-term planning, I don't want you thinking it's all gloom and doom. We just need to get more proactive about the long-term plan. I'm a planner. I like to plan 3, 4, 5 steps ahead. And it's time we make sure that our government officials are thinking about it and talking about it and letting us know that they're talking about it. It's not enough to do it in secret. We need to know they're doing it and where they are in the process so we can have that assurance. Heidi says, Tobago thanks you for taking the time off to share this information. P.S. Congratulations on your cover spread. Yes, thank you, Heidi. I'm pretty excited. My first magazine cover came out yesterday, and it was a joy. You know, as I said, I ended up on that magazine cover because in my podcast group, became friends with the magazine's owner, and she had asked me to write a piece for the magazine. Once I submitted my piece, she said, you know what, we love this so much, we'd like to make you the cover. Ruth says, I think we answered this for Ruth already. And so this is great. I think I made my way through most comments. If I did not see your question or comment, feel free to put it again and I'll quickly answer it. Working my way through, making sure that we've gotten everyone's, because there's so many comments. Love it, love it, love it. You know, so Earl says, let's see if I can catch this all. Earl, I'm going to have to put on my glasses for this one, huh? Woo! Here goes. Hold on. And of course, my glasses aren't around, but let's read it. You might have addressed this issue when I stepped away. If you did, then I wouldn't want you to repeat. Is poverty the issue or disparity relative to access to healthcare? Can it be that a main problem relative to high infection rate among Blacks is the fact that Blacks suffer more comorbidities, i.e. pre-existing conditions, than poor white people? Why is it that more Blacks are dying, comparatively speaking, even when compared to poor whites? That's an excellent question, Earl, and I will love to answer that. So what we're seeing, especially here in the United States, is that in some places, Black people are dying 6 times more than their white counterparts. In other areas, 3 times as many. And it's a multifactorial answer. So yes, Black people do have a lot of the underlying diseases that seem to be the biggest risk factors for severe COVID-19 disease. So those are things like diabetes, hypertension, asthma. We do see higher prevalence of those diseases in Black communities. But what we also know is there were a lot of misinformation sent out and propagated and reshared amongst Black communities that in turn led to people not taking the same safeguards initially. So, for example, there was one myth, unfortunately, that led to Black people sharing stories of Black people are immune. We're not going to get this. So as a result, they were still congregating, having cookouts, having parties, going to church, going to events. So that would have contributed. A lot of communities that are being hard hit happen to be in places where access to healthcare is limited. That's very true. And so that definitely is part of the disparity that we're seeing here is for many people, even if they were probably having symptoms, if they didn't have quick and ready access to testing and to care, then they wouldn't have found out about their disease until they were much more sicker and then headed to the hospital. And so, yes, that disparity is pronounced and definitely plays a role in urban and non-urban centers. Other disparities, though, that we're seeing, well, we happen to know that in terms of the messaging that went out about coronavirus and COVID-19, it was mixed. And so in many communities, depending on who you were listening to, depending on who your preferred media source was, you were hearing very different messaging from other people in your same community. And that led directly to what we're seeing here. We unfortunately had members even of the clergy who were out there saying that this virus was a hoax. We had members of very prominent factions within our society not taking it seriously. So that messaging definitely did not help as well. It did not help, that's for sure. Braylon says, I'm so proud you're speaking for people of color and for the Caribbean. Thank you, Braylon. I am speaking for everybody. You know, we're all human together, and we all need to make sure that we're heard. But we also need to learn how to appraise information. Janelle says, just joined. I'd like to know if you contracted the virus before and you no longer have it, is it a possibility of getting it again? Janelle, I did talk about this earlier. The question of whether or not you're immune from ever getting infected again is still up for debate. If we go based on simply what we know about coronaviruses in general, it would be fair to say that you're probably not 100% immune and will be infected again if you were exposed, particularly if you're exposed to a different strain of the virus and or if you were exposed to a particularly strong inoculum. And as an example, even though I was trying not to mention flu because this is not the flu, this is why we do flu shots, guys. It's not because the flu prevents you from catching the flu. The flu shot, it's not because it prevents you from getting the flu, but the reason why we do the flu shot is to help your immune system prepare itself so that if you are exposed to the flu, you can beat the flu without getting really, really sick and landing in the hospital. As a matter of fact, one of the flu vaccines is a weakened form of the flu virus, the one you inhale. It's actually what we call a live attenuated. So it's a mild flu infection so that your body fights that one off so that if you're then exposed to a really strong inoculum of the flu, you can then beat it and not find yourself in the hospital in the intensive care unit. That's where we need to get to with coronavirus. However, that's also the big difference right now between coronavirus and the flu is we have a vaccine for the flu, a proven effective vaccine that comes out every year. And the reason why we have to get one every year is because the influenza virus recombines, it mutates, it changes. So they have to keep doing what we call predictive models to determine what's the most likely strain coming. But we also have an effective medication for the flu. It's known as Tamiflu. We do not have that for coronavirus. We don't have a vaccine, and we do not have effective treatments yet. Not even the one that's being touted by government officials. We do not yet know if that is going to work and how effective it is. And we certainly know that there are safety questions related to it. Other questions, Mr. Watson Duke. How and when can a COVID-19 patient become cured, given that there's no known cure? So there's no cure right now. Our hope will be that as doctors and scientists do their due diligence, we will find effective treatments. And there will be one, guys. This isn't going to be something that you can't possibly treat. We just need to give it the time and do our part. We need to take personal responsibility and do our part while the scientists and the doctors and the policymakers and the public health officials get it together and figure out what's going on and what works. But in the meantime, if you have COVID-19 and your symptoms are moderate or severe, you need to be seen by a healthcare provider and treated, admitted, and supported. Right now, what we're doing is called supportive therapy primarily, but supportive therapy can slow the progression of the disease and your symptoms and ultimately help you recover. There are clinical trials as well, where they're looking at serum, meaning taking plasma from someone who's recovered from COVID-19 and using that to help treat someone who's currently severely infected. We'll know more from that as the results pan out. That can take up to 12 weeks before we get the initial results from those trials. But trials are forthcoming, absolutely. Hi, Dr. Jeffress, how are you? Sharon says, Doc, I'm so fearful of the flu shot. For the last 2 years, I've gotten extremely ill a week or so after the shot. I mean, sick enough that I'm home in bed. So, Sharon, I would talk to your doctor about this because it may not be that the flu shot necessarily made you sick. It could also be that you were exposed to the flu shortly before you got the shot, or it may be that you're allergic to something in the shot. There are different types of flu shot out there. And so it's good to talk to your doctor about it or your healthcare provider, because it may well be, I have some patients who only can get a special type of flu shot because they're allergic to eggs, right? And so many of the flu vaccines are actually propagated in eggs, chicken eggs. And so if you're someone who has some sort of a poultry allergy, that might not be that type of vaccine for you. Some vaccines have something called thimerosal, which is a mercury-based product, or aluminum, which is an adjuvant, as we call it, in the vaccine. If you have maybe an allergy to any of those things, then maybe that candidate vaccine is not for you. And so I would say, before completely refusing to take the flu shot, which of course is your right, you have the right to say you don't want to, by the way, but before completely saying no to it, sitting down with your doctor, having a conversation, figuring out what's going on is important. Lastly, remember I said there is a form of the flu vaccine that's actually a weakened version of the flu. So you're actually being given a mild infection. If that is the type of vaccine you're getting, then you will feel sick. You're going to have what we call the prodromal symptoms of a viral infection, which any viral infection pretty much causes you to feel a little bit weak, a little bit lethargic. You may have low-grade fevers, aches and pains. If that's the vaccine you've gotten, then that may explain your symptoms perfectly well. And again, all it means is you'll need a different vaccine. That's all that means. For Jacqueline, the same thing happened to me after I got the flu shot. I got sick really bad. Same advice, Jacqueline, same advice. For Avian, what are the protocols in dealing with the body of a person who died from COVID-19? Now, Avian, I've been talking to a number of people about this. I don't feel comfortable saying it myself here because I'm not a pathologist, but what I promise you is I'm going to get one of the pathologists who's currently dealing with COVID-19 to join me on live, and so we can talk about that protocol, because it's a great question. And it's a pertinent question because, indeed, part of the concern is whether or not corpses can be transmitting. Is there a possibility of infection? Do we need to bury very quickly? I know burial then starts creeping into cultural practice, and so we'll get someone who can talk to us about that in detail. Sharon says, thank you. I spoke with her, but we'll bring it up again. The flu shot is a requirement for work at the hospital. Yes, hospitals usually, if you refuse the flu shot, if you decline it, you then have to wear a mask for the rest of the flu season, which, by the way, as you guys have probably noticed, the flu season is extended these days, right? It goes on. Before, we would say by the end of February, early March, flu season is closed. Now it persists well into April and May. Odette, is there a minimal age to start the flu shot? Flu shots, yes. I don't think children get it before 6 months of age, and that's because you need an immune system. We encourage pregnant women to get the flu shot that's for pregnant women, because if a mom builds antibodies, those antibodies then cross the placenta and will actually help her baby protect itself when it's born for its first 6 months of life. But don't quote me on the 6 months. I have to remind myself. If there's a pediatrician who's on, or a family practitioner, do please post the answer if you know the exact age at which babies start getting the flu shot. Dr. Jeffers, how long until the antibody test is available? People are working on that. The big thing with the antibody test is currently it's what they're saying is cross-reactive, and so it's not very specific yet. They're still working on it. Now, the process of an antibody test, you can either look for antibodies in somebody's bloodstream, or you can look for protein of the virus in someone's bloodstream. And so they're assessing both. There's some tests on the market, but they're still checking that serology to confirm. Joy says, Dr. C, is there a chance of getting the COVID-19 a second time? Hi, Joyce. The thought is yes. What's the exact chance? We don't have those numbers yet, but we're seeing more and more reports of patients having another outbreak. Whether it's with the same strain of the virus, we don't know yet, but absolutely. Absolutely. Jacqueline, Dr. Duke, there are some people who have COVID-19 and have recovered home on their own. Is it because of ethnicity or individual immune system? It's multiple things, Jacqueline. I don't think it's just ethnicity. Again, I'm trying to debunk the ethnicity thing currently because I think it leads to a lot of either false assurance and unintended fear. Most people will get infected. Most people will recover. That's plain and simple. And so it doesn't matter what your ethnic background is, you're going to recover. Is there a difference, maybe subtle ethnic differences in terms of how one responds? People are going to be studying that, but we don't know that answer yet. But in terms of big picture and big mechanics of how the immune system works, it's not just ethnicity. Individual immune system, your individual immune response, yes, it plays a role, in part because for some of us, our bodies may have seen coronavirus type infections before. And so if that's the case, your body's immune system may be able to respond differently, but that may be a good response, or it may be a too strong response that really takes your body out. You know, I use fevers as the perfect example, which is a fever is actually your body's immune response to an infection, usually. Yet a fever can leave you feeling really wiped out, really sick. And if your fever is too high, it can actually cause damage to your brain and other things. Pregnant women, a really high fever can actually cause your pregnancy to stop growing. And so your immune response, while robust, can sometimes not be exactly what you need for survival. So it's nuanced. That's really the answer. Lisa, what do you think about the CDC loosening regulations on hospital workers to return to work after exposure to COVID-19? I think the CDC was under some pressure because we have a huge healthcare shortage in the United States, particularly in some areas more so than others. And so it's a moving target, obviously. I think the ideal situation would be if someone's tested positive, they should stay home. Exposure is different from testing positive. Ideally, if you had exposure, you should also be put in quarantine for 14 days, as they've done in China. The problem is if you have minimal PPE, someone or some people who are infected or asymptomatic have moved through a hospital, the majority of staff by the end of that interaction may have been exposed. That would mean shutting down an entire hospital and not serving the other truly sick people who need to be served. And so while it's from a gut reaction disturbing that exposed workers are being asked to go to work, it is understandable given the nominal resources that we have in some places. Absolutely. Babies are eligible for the flu shot from 6 months of age. I'm a pediatrician. Great, Dr. Cindy. Thank you, Doc. I thought it was 6 months, but you know, guys, I help people make babies. I see the babies when they come to visit, but I really very rarely see them for anything clinical unless I'm abroad doing charity work. And at that point, I really, catch up on everything that I need to know. Thank you, everybody. We're approaching the 1 hour mark. I thank you all for all your questions. Do please feel free to share this live. It's on Twitter, it's on YouTube, it's here on Facebook. Share it. If you have questions for me, you can send them to me. You can email them to info, I-N-F-O, at drcindyduke.com. Send me your questions. If you have suggestions for guests who I should interview, including if it's you, about COVID-19, please send it to me. I'd love to have them to talk about what's going on in the state of affairs. My homework is to get a pathologist who's dealing with this to join me live so we can talk about the disposal of bodies, because that's an important conversation, not just for those who are in healthcare, but for families. I mean, burial rites, burial practices is a huge part of culture and a huge part of what makes us human beings. If you look at even anthropology and they track civilizations, a big way of studying civilizations was looking at how they treated their dead. And so I know for a lot of us, that's a big question and a big concern. And I will do my homework, absolutely, and get back to you. Sharon says, thank you so much. You're amazing. Oh, thank you for taking the time to talk with us. Thank you guys for taking the time to listen to me, ask the challenging questions. I appreciate that too. And the whole goal here is to get answers, because the more informed we are, the better equipped we are to deal with this, but also the better equipped we are to start asking the stakeholders and the policyholders the questions that need to be asked and getting the solutions that need to come in order for us to get back out there and start living life. Because we're resilient. We will live. We will survive and will thrive, but we need their help. We absolutely need their help. Lisa says, Dr. Cindy, can ibuprofen make coronavirus symptoms worse? There is conflicting data that says in someone who has COVID-19, NSAIDs, non-steroidal anti-inflammatories might be exacerbating symptoms. Again, what's being recommended right now is leave that decision up to the healthcare provider. So that's my short answer, is the general population. If you don't have to use NSAIDs, don't right now. But if your doctor says you should, follow instructions, please. Janelle says, very informative, and thanks a lot. Thank you, everybody. Take care, and see you tomorrow. Bye.